Paul asked me to present a challenging case of transcatheter mitral valve replacement, and I kind of had to think about, what replacement means in the current era, and the whole definition of replacement in the mitral position continues to evolve. We saw a case of complex valve and valve case earlier, but there's valve and ring, valve and MAC, and then there's a traditional full-on valve replacement where you take a structure and put it inside the mitral valve, the native mitral valve, and we have Tendyne and Intrepid, and obviously there's other things that are in the pipeline, such as M3 and 4C, but we haven't done our Tendyne yet. Probably, hopefully, in the next couple of months, we'll do our first Tendyne case. But I thought we'd talk a little bit of a complex valve and ring case we did recently. And I saw Danny in here earlier. Hopefully, he's still in here. I'd love to get his input on this case. It was a young female, 69, but she was 69 going on 99. She had multiple comorbidities. A little over a decade ago, she underwent an annuloplasty ring, a number 26 physio, and also went a tricuspid annuloplasty at that time. She's had recurrent recent CHF admissions over about 6 to 8 months or so, and her transthoracic showed that now she had severe bioprosthetic MR, and then she also had some mitral stenosis. Her transthoracic echo, again, confirmed that there was regurgitation, there's flow convergence and diastole, consistent with some transmitral gradient. The gradient was about 8, which may or may not be terribly abnormal for this type of valve. And here are some transesophageal echo images kind of confirming the same. There's this very eccentric, kind of abnormal appearing regurgitant jet in this giant left atrium that was performed about a little over a decade ago. So, we kind of met with her. STS score was certainly above 8. She had substantial pulmonary disease, very small, frail lady. Her rehab potential was pretty poor, especially for a sternotomy, but also for a transapical approach. We really felt she would not tolerate that well. So we ended up electing a femoral venous, a transeptal puncture, and then try to deliver a SAPIEN S3 system under rapid pacing. So this is from the Valve and Valve app, and as I learned, during this case, these are semi-rigid rings, the Physio 1, and the alloy is a cobalt chromium alloy, and they're generally rigid along here anteriorly, and then they're a little bit more flexible here in the posterior section of it, and this is kind of what it looks like on the bench top, and then under fluoroscopy when you're looking at it on FOSS. The Valve and Valve app recommends a size of 23 on the SAPIEN system, and this is kind of what it would look like once it's deployed. You're trying to look for at least a 70-30. Here under fluoroscopy, it may even look 60-40, and then with the understanding that, again, the shortening occurs from the atrial side down once you're deploying it. We also routinely do our own CTs and our own reconstructions, and we're getting diameters of about 24 to 17 with an average of about 20 or so. And in her particular case, the neo-LVOT was not a concern, so we weren't really too concerned about that. She had a ventricle that could tolerate it. So we performed a transeptal puncture posteriorly, dilated the interatrial septum, and then we created an LV rail. And this is an important point for discussion because I think if you're able to externalize it through an apical hole, you get better coaxiality when you're trying to deploy the device. Other people have kind of taken it out the aortic valve and kind of snared it and then kind of used the femoral vein to maintain some degree of coaxiality. But that is one of the limitations of this type of replacement. And as you can see, it may have caused some problem down the line. So as was mentioned earlier by Dominik, the sheath, you cannot advance it all the way in. You have to leave it out, and you actually mount the valve inside the IVC. And she had a very big left atrium, so we had to use this banking technique, kind of banked off the posterior wall of the aorta and finally bring it across the ring and began to put it into appropriate position. So here we are. We kind of understand the marker, the middle dot marker is kind of at the level of the ring, but most of the shortening is going to occur from the atrial side down. And again, we're shooting for about 70-30, 30 on the atrial side, maybe 40. We'll tolerate that. And LVOT obstruction was again not a concern for her. So we're beginning a rapid pace here on the bottom left, and the balloon is beginning to inflate. Kind of we're making micro adjustments as we can, and so far everything looks pretty darn good. Kind of like the positioning. We can see that the parallax, we're losing some of the parallax, so the valve has shifted a little bit. But we go ahead and take it. And this is kind of what it looks like afterwards. We do have a nice hourglass figure. There is a parallax, so maybe on one side we really are 70-30, but on the other we may be closer to 50-50. And this is the echo right afterwards. So what we have is, the valve itself is nice and well seated. However, there is pretty substantial paravalvular insufficiency, or in this case, para-ring insufficiency. I mean, between the ring and the prosthetic valve, there is no insufficiency, but probably the ring itself dehisced from the tissue as part of our deployment. So what is a mechanism? You know, the one mechanism is that, you know, you're taking a round structure and putting it into an oval structure. And so that creates a lot of tension on the ring itself and pulls it away from the tissue, and certainly that can contribute to formation of this para-ring insufficiency. And a lot of that may have to do with coaxiality. And you know, we're learning more and more about valve and valve and ring. You know, if you look at Danny's, at least the data he presented last year, you know, about a third or 80, he had like 80 patients or so, and the vast majority of them had the Edwards physio ring. And one of the mechanisms is coaxiality. Now, if you look, we normally look at it in the RO projection where we have the ring lined up, and we think that we're totally perpendicular, but we usually don't look at an en-face view, because in the en-face view, we still could be not coaxial. This is kind of what we would ideally like to achieve, but you could tolerate this too, and you could probably tolerate that, but what you can't tolerate is when it's canted off the side, and you really can't tell that when you're looking at it just from the side, and you really need an en-face view, and whether that's, you know, 3D TE or whether that's fluoro, you know, you can use that, but even if you have detected it, well, how do you achieve that coaxiality, especially if you don't have an apical extrusion in the rail coming out the apex side. So this continues to be a challenge for these valve and ring procedures. And so here, this is on the left, you'll see right before we started to deploy, this is where the position is, and look at the ring, it's totally perfect, perfectly in plane, and then as soon as you see the ring with maximum deployment, the ring is totally shifted. So we really lifted it off where its base, and likely, again, because of lack of coaxiality is probably what did it. So even if that does happen, you know, we kind of detected the mechanism. At this point, what do? You know, we elected to proceed with para-ring closure. We were able to get an Agila sheath in there, use 3D guidance to get two glide wires across here on the left image, and then ultimately we sized the defect with the help of transesophageal echo imaging, and we went ahead and deployed two AVPs. This is kind of the final picture. You do have to confirm both in the en-face and the side view that you're truly not through the valve, and you want to be, and not actually also through one of the open cells in the ventricular side. You were in the appropriate position. So we had good deployment. On the left here is the pre. On the right, you see post valve and ring, and then finally after the AVP went in, we had good seal of that para-ring leak. So 23 Sapien S3 valve and ring, we put two vascular plugs in, and then a crib to close it on the way out. So you know, I think for these valve and ring procedures, I think these transfemoral transeptal approach is certainly feasible. These para-ring leaks, I think, are also feasible, but that is one of the limitations currently of the valve and ring procedure. The mechanism we talked about is just not having appropriate coaxiality, and even if you do detect it ahead of time, trying to get that coaxiality without having an apical rail is challenging. And then obviously just the sheer fact that you're taking a round structure and putting it inside of an oval structure and trying to make it conform to that can be difficult. So the patient fortunately did well, and she did great, but again, this highlights some of the issues that we continue to have with valve and ring procedures. So thank you.
Just one quick comment. Great. I think having two wires across and deploying two is a great alternative. There, what we have in Canada, we have the AVP3, which is more oblong for peridevice leak. So,
Nice.
you know, typically we just use one to start. But great case, though.
Yep.